The mic, oh, good. Go ahead, turn this one off. Perfect. And as the whole state, I imagine, as we're having these conversations, mental health has become an area of public health concern for the past few years. In particular, in our area, youth mental health, which is what we're going to focus our brief presentation on today. And I'm presenting with Jamie, who actually is a community partner and champion who organically started a coalition in our area to address mental health and youth suicide. Which, when does that happen? Organically created coalition, which is fantastic. So why are we particularly concerned in Saginaw County? We were looking at our Maine Integrated Youth Health Survey, which if you don't have access to and use that often, I encourage you to. And over the past, I would say 3 surveys, so that's 6 years, we were starting to see pretty concerning trends in our area. So we were seeing that 29% of our high school students reported feeling sad or hopeless, and only 21% of those kids reported getting help from an adult in the past year. This is at state average now, but over the years it's been trending a little higher. 18% of our middle school students and 19% of our high school students had seriously considered suicide in the past year, and that 19% is higher than state average in 2015. And then this was the one that really got us and hit us in the gut, was that our kids don't feel like they matter to the people in our community. And when we shared that slide with community members, I think it really makes an impact. In addition to the data, this is what we were hearing, as many of you probably as well hear from your schools, that this is what they're concerned with. They're concerned with tobacco, they're concerned with wellness policy, but really, what can you do for us to help with the mental health concerns that our kids are sharing with us? And we'd had several community experiences that Jamie's going to touch on that really told us something's going on and we need to help these kids. So this was the data that I had as a grant writer to work with, and we started thinking about what can we do as a hospital and as a community health coalition to help our community and address this. So one of the things that we also looked at, we have a pretty strong substance abuse prevention coalition and program in our area, and we wanted to look at the data to say, not only are we concerned with the fact that our kids have mental health concerns, but also, what does that also correlate to? And what we could see, as many of you realize, is the kids that were saying that were sad and hopeless, which are those red bars, are also more likely to use substances, from cigarettes and alcohol to marijuana and prescription drugs. So we knew that there was substance use tied to that, and so we were able to use that and use some of our drug-free community money and some of our state substance abuse money to start to tease that out a little and really use that also to our advantage in seeking funding. So what were our options? That was the thing I struggled with as a public health professional. I realize it's a concern. I know there's something we need to do, but what can we do as a hospital, as a public health entity that's not already being done already? So if you look at the Garrett Lee Smith Memorial Suicide Prevention Program, these are all the recommendations on what should be going on in a community to address suicide prevention. These in yellow and red are things that we thought, this is pretty unscientific, by the way. This is just talking to people, talking to teachers, talking to community folks on what was already happening. What do we not need to do? Probably some of this we could enhance, but what is happening in our community? So we started there. We knew that there's a requirement of gatekeeper training. We knew that there's suicide hotlines and helplines. We know we had NAMI there as a partner. We knew all the schools did have policies and protocols. There was some outreach and awareness going on. We had a coalition at that point. It was very chronic disease focused, but with lots of concern about mental health. So we knew, and we have some direct services. We're lucky that we do have some mental health services in our area. We also had a lot of existing partners, strong partners. So if you've gone to any of the previous presentations today, you've heard about NAMI, and you know that they offer a lot of free assistance and support. And they were offering youth mental health first aid trainings, and they have an expertise in suicide prevention. So we knew that they were out there and that they could be a partner, helpful partner. We had our local schools who were very interested in partnering, again, asking us what we can do together. We both are served by Sweetser and Maine Behavioral Health in our area. We have Access Health, which is a local coalition that I mentioned, Community Health Coalition. We had several concerned community members, and we had Midcoast Hospital, and my hospital has strong community ties, is very concerned about public health, and has some expertise on staff. So then the question is, what's not going on, and what do we have the capacity to do? So we really looked at where we're strong, and that's we have great coalitions and partners. We have places to refer, so we thought, I think one of the things that needs to happen is we need to get those referrals to those professionals that are already out there, and we need to increase our outreach and awareness. This we felt like is something that we could do, we had the expertise to do, and was needed in our area. So this is when we came across the first cohort of youth mental health first aid grants that were released by SAMHSA. So the idea behind youth mental health first aid, if you haven't heard, is to identify a kid that might be in crisis and to connect them to services. So it's getting that layperson expertise and tools that they need. The funding is from Now is the Time, Project Aware, which is a community grant from SAMHSA. I'm not sure if it's being released again this year, but if it is, I'd put it on your radar. And it was a 3-year project. We got $125,000 a year. Our goal was to saturate our community with trained first aiders. We knew NAMI was there, so we didn't want to be or need to be the expert, so we wanted to, and we are strongly partnering with NAMI to actually facilitate the trainings. We were able to hire a coordinator for mental health literacy, which is the other part of the grant, and to coordinate the community trainings. And I think the most important part of the grant that we wrote in was to support teacher stipends or substitute costs, so that if teachers or schools wanted to send their teachers, we could support that, and that's what we were hearing that they wanted and that would help. So if you haven't, just really briefly before I turn over to Jamie, what the course introduces is what are some common mental health challenges that our youth face, what's typical adolescent development, so that if you know typical, as a mother of adolescents, that's a tough one, but there is some expected typical development, and when is something maybe atypical. And then you'd actually develop a 5-step action plan on what you're going to do if you come across youth in crisis. These were our goals. Again, pretty common grant goals. We wanted to increase the number of, have trainers, get first aiders, and then increase some literacy and get more kids referred that need it. So how is it helping? We just started our 3rd year. We have increased the number of adolescents formally assessed by Sweetser and Maine Behavioral Health. The goal was 300 in year 1, and we get to 565. I'm sure that's not all this grant, but still, it's good that more kids are being referred. I think it's a sad but a positive number. And we want to increase the number of partnerships with local community agencies. And these are both formal and informal. So our goal was 50. It's a resource guide for anyone working with youth on where to connect kids to. But these are things like helping a kid that's disengaged become engaged. So it could be our local 4-H's or big brothers or big sisters. So I think the informal piece of this is just as important as the formal. And then overall, just so you know, in 3 years, we've had 14 trainings and 214 people total trained. Some of the positive feedback about people that have gone through the training, 3/4 reported they were better able to identify and assist youth who may be experiencing mental health challenge or crisis and feel more confident in being able to assist such youth. And that was really our biggest goal. And a few of the shared success stories from people that have gone through the training, that they're able to see more signs, they're using the newfound knowledge to better interview potential staff, which I thought was a great outcome. And especially the ones that actually said, I helped someone, this really helped me help someone in my life, which is great. A few barriers, just as always, our intent was this big. The schools were really on board and really thought that we were going to schedule all these great school trainings. And then I think when we started to come down to the logistics of a whole day, the schools had a lot of competing priorities, so we're not doing as many school trainings as I had hoped. We are certainly doing some, and quite a few, but I had this big dream to become flocking to me, but didn't quite happen that way. But on the other hand, our community trainings are a lot stronger than I thought, so it's a bit of a balance. So I'm hoping in 3 years, now that people know that we're out there, that we'll even have more people show up. So meanwhile, though, in the community, while this is happening, we have the Midcoast Community Alliance that formed, and I'll let Jamie take over. And Jamie is from Bath, and I'll let her introduce herself.
Good afternoon, and thank you for having me here today. I am a volunteer with the Bath Youth Meeting House and Skate Park, and over the past 5 years, unfortunately, we have lost a number of young people. Back in July of 2016, after losing yet another young life, I was working with the phenomenal group at NAMI, Maine, to coordinate grief counseling services. And at that time, I met with Greg Marley and asked him, what are we missing as a community? What are we doing as a community, or what could we be doing as a community to become more proactive rather than reactive? And so what he told me at that point was every community is different. There isn't necessarily a model, but start small. Get a group of people together and start a conversation. Sorry, wrong way. So we started with our local guidance department at our high school, the Bath YMCA, Bath Parks and Rec Department, and NAMI, Maine. And in July of 2016, we had our first meeting, and we talked about all kinds of different risk factors and what the schools are seeing and where we're missing resources. And from there, we decided right away we needed to have law enforcement be a part of this conversation. So they came the next month, and that's when they connected us with a very dynamic group at Midcoast Hospital and Sweetser and Maine Behavioral Health. And from there, it just really exploded. So by the fall of that 2016, we had 25 different organizations. We now have all 3 school departments, RSU1, Brunswick, and MSAD 75 involved. We have suicide survivors, we have students, community members, churches that all come together once a month to talk about what are we addressing and what are we doing. And so we have over 70 community members connected in some way to the Midcoast Community Alliance. And we started to look at the Maine Integrated Youth Health Survey that Melissa was talking about. And in Saginaw County, we had 19% of students seriously considered attempting suicide. 26.2% had reported being bullied. 28.7% felt sad or hopeless. And so we started to ask our law enforcement, over the past 5 years, how many people have we lost to suicide? Back in March, that number was 20 community members in a very small Saginaw County. It didn't include Brunswick or Harpswell. And 9 of those were in our city of Bath. Unfortunately, as we saw during late spring and early summer this year, those numbers increased. So once we saw the statistics and what we were dealing with, we held a call to action. It was hosted by our police chief, Mike Field, and the National Alliance for Mental Illness in Maine. We had over 125 people attend. We had exhibitors, mental health agencies, churches, student groups, all set up around the perimeter. We created a resources booklet to help highlight the work that 211 United Way has been doing. We had 3 speakers that included a mother who lost her son to suicide, a man who struggled with addiction and is now living in recovery, and a teenager who lived with a depression who once attempted suicide, who later lost a close family member to suicide. The response from our community was very well received. And in the weeks following, my phone was ringing off the hook. We heard from teachers, we heard from students, we heard from parents, and we were able to connect them to the many great resources that exist in our community. We also, as Melissa mentioned earlier, discovered that only 49% of the students at our high schools felt like they mattered to the community. So one morning, a very rainy morning in May last spring, We gathered as many different community members as we could, the city manager, city council, Bath PD, Bath Fire Department, and just parents. And we lined the sidewalks with posters that said, "You matter." We handed out wristbands that had positive messaging, the statewide crisis hotline, and also a link to a very inspirational video that we created just for students. And again, very well received. And these sorts of events have allowed our conversation, or our community, to have very difficult conversations. And it seems that every week I'm getting contacted by parents or survivors who are ready to tell their story. So it's really been an incredible thing to be a part of. We're also hearing from high school students who are advocating for greater mental health awareness, so we're able to coordinate with Midcoast Hospital in Nami, Maine to offer different options so that each school can customize what is right with them. And I apologize, I'm not keeping up with my slides very well. We have created a very informal wraparound committee to meet the needs of 12-year-olds who aren't living at home in our community, and various things like that. We're also working to amplify the good work that's being done, so we are just as committed to trying to get as many people, youth mental health first aid, trained as possible. And we had a very successful event over the summer and are hoping to continue that. Where we're going in the future is to continue this conversation in a very public sense. We are hosting events to educate on adverse childhood experiences. We are hoping to create a suicide prevention video series that we can then use with search engine marketing. So as our teens are searching on anything related to suicide, hopefully they will be met with our message of hope and help. And we are continuing to build a network to share resources and identifying gaps, and then trying to find creative ways to solve the gaps that we do have in our community. You can learn more about us on our website, and also follow us on Facebook and Instagram. Thank you.
Thank you. That was a great presentation. Gives us all some hope. We will have some time for questions, but we're going to move on to the next presentation right now, and we'll have the questions at the end. And our next presenters, we're really happy to welcome Jean Gold and Bonnie Carlton, and they're from Maine Health, presenting on hospital to home, improving patient transitions through a multidisciplinary approach.
So I've never used one of these microphones before. Can everybody hear me okay? Awesome. So thank you for joining us today. My name is Bonnie Carlton, and I have my lovely colleague Jean Gould with me. We are from the Maine Health System, where we work at the Maine Health Learning Resource Center, and we'll get a little bit more into detail about what we do. And then we're going to talk about the hospital to home program and how that multidisciplinary approach really improves patient transitions through care.
And my name is Jean, and I am covering this morning or this afternoon now, for Kayla, who is not feeling well. So bear with me, please. Bonnie knows this inside and out, but I've been involved in the hospital to home program a few years back. So I'm here to do part of the presentation and to help with that. So we are going to get started.
Okay.
So I am going to start off by just kind of talking about who we are within the Maine Health organization. As Bonnie said, we work in what's called the Learning Resource Centers, and that's also part of the community education program within Maine Health. So we have kind of two arms of what we do within our program. We have the community education program component of it, which is a little bit more provider facing. So we do things across the system around, we offer health literacy for the system, we offer focus groups for any members or practices or programs that might need to assess a need in a different way. We offer our advanced care planning. We're very involved in initiating and encouraging individuals to complete their advanced care plans. So we have trained advanced care facilitators who work with different member organizations and providers across the system to support that Maine Health goal. And we also are involved in provider coaching to offer some feedback to providers who are working with patients on how they might be able to better connect with their patients and how they're communicating and communication styles. So we work with them on that. And then we are also involved in EPIC referrals. So now with EPIC being rolled out across the system, the Learning Resource Center is in there as a referral so that providers can then refer patients to the Learning Resource Center to provide our services. So with that, I'm going to transition over to kind of what we do as far as the Learning Resource Centers. We have 2 physical locations. We have one in Falmouth and one in Scarborough, and they're both set up very similar. They're lending libraries with health education brochures and books. You know, it's a consumer-based library. We're staffed with health educators at each location. And then we have access to the internet in both locations. And in our Falmouth center, we have a kitchen. So part of our services are offering health educators to our communities to be able to support community members with any health needs or questions that they might have, and understanding what resources are available to them. We offer community-based classes, so we put out 2 class catalogs a year, and we're all staff is responsible for coordinating and offering these classes. So for example, last night we just did a roll your own sushi class that I led, which was a lot of fun, and gets people to try different things. We had a protein bowl class. So we offer a lot of different community-based classes, and we try to also align that with the Maine Health initiatives, so around heart health and diabetes and cancer prevention. So our classes are focused along those lines. Am I missing anything?
I think you hit all the big
Okay. So that's kind of who we are in a nutshell, and Bonnie is going to go a little bit more into the hospital to home program and how we got involved.
So as Jean mentioned, we do a lot of different things. We're all over the place helping people left and right. And one of the big programs that we're involved with is the hospital to home program. I'm going to refer to it as H2h for time's sake here. So H2h was started about 10 years ago. It's a collaboration with the family medicine program. We now meet twice a week. There's one H2h office visit in Portland. They meet on Wednesdays, and there's one over in Falmouth on Friday mornings. So when we're describing it to patients, we call it a one-stop shop. It's a multidisciplinary approach. Patients are able to meet with a wide variety of healthcare providers at one visit in one room. And although multiple patients may be there at the same time, each patient receives individual attention the whole time. And everyone is asked to sign a confidentiality form just in case they happen to overhear a conversation between a patient and another provider, but that doesn't happen. We really spread out. We use the room. They're meeting one-on-one with their providers. Some people call it speed dating, and we laugh and we say, yeah, you know, kind of. Speed dating with your healthcare providers. So the meeting itself, all the patients come in. We encourage them to bring a loved one with them. And we start off with a brief introduction. All of the providers will go around the room. I'll say, hi, I'm Bonnie. I'm the health educator, and the pharmacist, and all the rest of the team will do the same. And then we'll all split off, kind of round robin rotate throughout the room. And each meeting takes about an hour, sometimes a little bit more, sometimes less. And throughout the course of that hour, patients will have the opportunity to meet one-on-one with a nurse care manager, behavioral health professional, a health educator like myself, a pharmacist, and a physician. The nurse takes the vital signs like their weight, blood pressure, and temperature. The nurse care manager will assist with care coordination and discharge instructions. The behavioral health professional usually teams up with the social worker, and they'll chat with the patient about their mental health and talk about any other unmet needs that they have going on outside of their immediate health care. The pharmacist will go through the medicine list and check for patient understanding, make sure they have enough of their meds moving forward, they'll make adjustments as needed and make sure, they know moving forward what they need to be doing. The physician will talk with the patient about their medical diagnosis, clarify any confusion about the discharge instructions they had leaving the hospital, and they'll place any further referrals as needed. And Jean is going to go more in depth about our role as a health educator on the H2H team.
So being involved in H2H has kind of evolved over the past few years. And again, with the rollout of EPIC, the EMR that Maine Health is using across the system, we were then able to be integrated into the process with the EMR, and then also being integrated into the process with the practice, therefore being embedded in this transition program to be able to prevent people from who have been in the hospital now being out of the hospital and to prevent them from going back in. So our role has been now, currently, there becomes, before the visit, we go into the EMR and we're able to look at the patient's chart. So we're able to assess what they're coming in with, why they were in the hospital, any other comorbidities that might need to be addressed. So kind of preempting the needs before we actually meet the patient. So we're able to then gather some information and come to the visit with some things that we might be able to offer them at the time of the visit. During the visit, we spend some time with them doing some motivational interviewing. Our staff has all been trained on how to communicate with patients to really kind of get to the underlying concerns that they might have, and help get them motivated to think about what things that they might be able to change, make some changes, and what they need in order to support those changes. And we work with the teach-back methods, so we work a lot with communication and hoping that they understand what we're communicating about. So as we discuss different options, resources that are available, we'll use the teach-back method to understand, to help us make sure that they really understand what they're being told and what resources are available, by having them repeat back some of the conversation that we've had with them. And that helps to ensure that they really are understanding what we've just talked about, because it can be overwhelming and confusing. And we're also using this time as an opportunity to kind of initiate advanced care planning. So it's a way to open those discussions, let patients know that this service is available, that we have trained advanced care planning facilitators in our physical locations, and that we can help people fill out those forms because they can feel overwhelming and uncomfortable, and so that we have people to support them through that. So lots happens during the visit, so it's kind of exciting. And then for follow-up, we work with them a lot around setting up goals and what their achievements, what they want to achieve in order to make some healthy changes. We give them health information, and sometimes what we think that they're going to want isn't always really what they want. So we might need to circle back with them. If we are going and thinking, this patient has not managed their diabetes very well, and we're going to offer this, that, and the other thing, we might walk out of that and they're saying, well, I really just need to know where I can get insurance, or I need to know where I can get my medications. And so we're able to close that loop and follow up with them, either get that information during the visit or to follow up and provide that to them afterwards. And again, we help to set up the meetings with the advanced care planning staff if they're interested in doing that, and to continue that conversation.
And so this is a picture of the whiteboard that we use in the room to keep track of the provider interactions. And this is especially helpful if there's more than one patient in the room. It's really easy. The facilitating nurse just puts a check mark next to each provider as the patient meets with them. And once the patient gets all of their check marks, we send them on their way. We have a lot of people come through and they tell us, they walk into this room, there's a huge table full of people, and it makes them really nervous. They're like, is this an intervention? Am I okay? And by the time they leave, they are so grateful for the convenience of the one-stop shop, and they can't stop singing the praises of how amazing H2H is, and thank you for offering this service for them. So they come in, they're really hesitant, they're kind of dragging their feet a little bit, But by the time they leave, they're really thankful, and they say, if I'm ever in the hospital again, I really want to come back to this. So we consider that a success.
So as Bonnie said, the family medicine practice definitely uses a multidisciplinary approach, and they're in a practice that they're able to do that. So it's been really beneficial for the patients that come through this group visit to have access to all these people in one space at one time during a critical time for them. So the team is made up of a pharmacist, the doctor, and typically they might have 2 doctors and potentially a resident, or one of the doctors might be a resident, but there's always a lead provider who's there, and then the social worker and a health educator and a registered nurse. So typically that the patients, or all the patients who are in this group visit, will meet with every single one of those disciplines to be able to address each of those needs. Pharmacy has tended to be a huge asset. A lot of people struggle with understanding their medications, getting access to their medications, paying for their medications, knowing what things that they interact with. So having that person there to be able to talk to them at that time has been significant. And then also with the provider, they do their regular kind of checkup, but they're following up on what happened in the hospital, why they were in the hospital, and having the patient really understand what happened, because oftentimes when we're sick and an event happens, we don't really remember what happened in the hospital. It's kind of a blur. So the doctor is able to kind of walk them through that, help them understand what treatments they had, if medications were changed in the hospital and why, and then the pharmacist is there to kind of support that. And the social worker is another great asset, where these people might need some community-based support systems set up. So they're there to speak with them directly to get those in process immediately. So the social workers will also everybody plays a crucial role, but the timeliness of it seems to be what really makes it work. And then, the RN, again, kind of that support system, following up with their vital signs and helping them know what to do when they get home, and making that connection and helping them understand their any other conditions that they're dealing with at the same time. And then the health education staff is there to support, to know, for patients to know that we're there as a resource to provide additional resources, information. We're a free resource that people can continue to come back to and utilize, and offer our support. And so it's one place that people can continue to come back to and utilize, and we're there to support them across the Maine health system.
And one thing we did forget to put in this presentation, but I think it's really important to mention, is this whole group visit is just billed as one office visit. So people that have Maine care and things like that, this is just billed as an office visit. And as with any great program, we've encountered handfuls of challenges and successes. Some of the challenges that we see with the H2h program include inconsistency with the use of the electronic medical records, health and economic disparities. Some of the patients we see don't have adequate access to proper health care, and some don't have a reliable method of transportation. Some patients are dealing with financial struggles and are not able to make their health care a top priority. And one way that the Portland office has managed to meet that transportation issue has been moving the start time from 9 a.m. to 10 a.m. So that gives the patients a little bit of extra wiggle room there to get a family member to drive them, or to catch the bus a little bit earlier. Another challenge that we see has been substance abuse, which of course can affect health conditions and can sometimes create a whole new subset of disparities. And lack of self-efficacy is another big challenge. Sometimes people don't feel confident to take those measures they need to keep themselves healthy. And lastly, low health literacy skills can really affect a patient's ability to understand and take care of their health conditions. So there's the challenges, but over here we have all these great successes. So at these H2h visits, we're able to provide clear and concise health info. We meet patients where they're at. Most of the time, the patients are living really close to the Portland and Falmouth offices, so it's nearby. We're not asking them to travel really far for it. We bring the information to them, or if they ask for information that we didn't happen to bring for them, we follow up and we'll send it over to them, give them a phone call. Either way, whatever makes the most sense for them, but we put it right in their hands whenever we can. We help them set healthy goals, and most of the time we're able to get their advanced directives on file, which is amazing and a really big push right now.
So as with any program, there's always areas for improvement and ways to look at things and how they can be done differently to make it an even more effective program. So one is to continue the increase for advanced care planning, so that in the event of an emergency or a crisis, that the medical staff knows how to treat that patient and knows what their wishes are. Data collection, collecting more data around readmission rates and what happens to the patients when they leave. So kind of collecting that information to see the efficacy of the program. The PDSA cycle, using that a little bit more, which is the plan, do, study, and act. And that's a great tool to do quality improvement measures.
Yeah, we'd also love to see an updated H2h handout. There's currently one that is given to patients before their visit, right when they're leaving the hospital, but it's pretty vague, and people, as I said, are still pretty overwhelmed when they walk into the room. And we think that maybe creating a handout with pictures of each of us providers with a brief description about what we'll talk about underneath our picture might be a really good idea. And in that same handout, we want a section on there for patients to write their questions and concerns before they walk into their appointment. Because I know sometimes I walk into the doctor with 5 questions and I leave asking maybe one of them, like, shoot, I forgot to ask that very important one about my asthma. So if we put all of their questions down, they can look down and reference it and make sure they have all their questions answered. And lastly, we've also been playing with the idea of having some sort of prescription pad. You know how doctors have a prescription pad to write down medicine? We think it would be really cool if they could write a prescription for health information and send their patients to see us at the Learning Resource Centers. This might be thinking a few steps outside of H2H, but we might be pushing for this idea in several doctors' offices in the near future. So you might be seeing that in the time to come. And with that, I think we're going to move into the question section.
We do have time for questions, and the questions would be for both of our presentations today. So if you would like to join us there. Any questions?
I'm a big fan of evaluation, and I'm wondering what each of you are would like to do in your programs and your implementation.
You're a woman after my own heart. We actually hired Data Innovations, Cutler, Sarah, to evaluate. So we have an evaluation built in, and then we, like I said, we also really take a deep dive into our MPHAs, and so we're really excited in 2017 to see where we're making a difference and if our mental health numbers change and if that affects some of the other markers. So we hired it out.
And for us, is this on? Can you hear me? I'll just speak really loud. For us with the H2H program, as we mentioned, one of the areas for improvement is data collection. Right now, we're not collecting an awful lot, and that's not necessarily something that we as health educators can do, but we're trying to really collaborate with the team, maybe you, pointing to yourself, we'll talk after. But we'd love to see, specific data about how much this is decreasing hospital readmission rates, because we know it is working, we just don't know how much at this time.
And I know I did the hospital to home when it, in its inception, probably 6-7 years ago, and they were at the time collecting data about readmission rates, and there was data that showed that readmission rates went down, and the practice was collecting that, so I guess it might be something that could be considered moving forward to continue to do. But I think statistically across the nation where they've done these group visits, statistically it does show that there's a decrease in readmission rates. Yep.
On the H2H program, how do you select the patients that are going to be engaged in, I'm assuming it's not happening at the hospital, they've already gone home. How do you how does that work? Help me understand how that works there.
So,
Some place? I was a little confused how they
Sure.
got engaged into that program.
Sure. Sorry for the confusion. We had to kind of condense our hour-long presentation into a 25-minute. But so the patients, they're getting ready to leave the hospital. They're getting all their discharge instructions, and then one of the discharge nurses will bring up this idea to them, and they have the option to either say, yes, I really want to go, or no, maybe I don't need this. So they're given the option, and then we schedule them for the visit the following week, or if they're discharged on a Monday, we'll get them in that same week, Wednesday or Friday.
So the referral does happen.
For you to have would then be what type of patients are coming to see you, because that can certainly impact the outcomes that you have.
Yes, and we're able to look at all those records beforehand, before the meeting.
So I'm wondering what kind of resources you're connecting folks to for the literacy piece afterward. Are there, you said something about classes, but I'm wondering if you could elaborate a little more.
Well, the Learning Resource Center, we're all trained in health literacy, so we do a lot of health literacy across the system, and we're able to, one, work with programs and the system to help them rewrite their patient education materials. And with that, we're also trained in being able to identify resources and information that is written in a way that's more accessible to patients. So that's basically what we would do with patients, is provide them with resources that we have vetted that are more accessible than other patient education might be.
Just one follow-up. Is there information in there or data being collected about food insecurity and whether or not there might be a connection to emergency food or other resources like that?
Not that, yeah, I don't know if they're collecting any of
No,
that,
not
but I
that I've
don't think
ever
so. Yeah.
been aware of.
This gentleman had a question.
Yes, I have a question about what percentage of people accept the invitation, because that's going to involve a certain selection bias in terms of interpreting the impact. Yeah, I totally support it. We stole the idea from the residency and used it in residency at CMMC.
Yeah. I don't think that we have that data. Again, it's because it's led by Family Medicine Center, and they're the ones initiating it. So I don't have that.
Those patients are coming back to their clinic.
Correct.
to follow up.
Yes. Yes. So all the patients that are seen at either Portland or Falmouth are patients of those practices. Yeah. And they're highly encouraged to come, and I believe if they don't come to the group visit, there is still a follow-up with the patient.
I'm curious about the funding aspect. You mentioned that from a patient perspective, it's great because it's only billed as one visit. How do the practices support that? Because it's an hour of 5 different providers' time.
It's another good
That's
question.
a great question.
We don't, again, have that kind of data, but they have made it work for their patient population, and because family medicine has a rather large staff and a multidisciplinary staff, they're able to pull in the staff at that time. And some of the staff members, like the social workers, might not be in the room the entire hour. They might get pulled in as needed. But I know that the doctors, the pharmacists, the health educators are all there for the time. Otherwise, they'd still have to see the patients individually.
At CMMC, they give us a large pass because you prevent one hospitalization, you're covering a lot of personnel hours, and these are people who are already getting paid for being there.
Right.
So it didn't involve extra hours, it involved coordinating.
Yeah.
That's a great point.
Thank you.
Is there anybody else before we go back to people who already asked? Any questions about I'm interested in mental health questions. It's always a hard community issue to tackle, and does anybody, I have a question, but does anybody have another question?
What work have you done with youth specifically in terms of spearheading projects around this?
We had a great Brunswick High School. We have some really great contacts there. So we have reached out to several you have to, we actually want peers to take the youth mental health first aid because we feel that they're going to be the ones first to know if something's going on. They have to be 16 for the program, and so we've done in one high school we had a peer training which went great, and so we're hoping, and we've had the invitation out to other youth groups in high schools if they want a group of youth trained. We would love to do that, and so we're doing that aspect of that, which would be great.
And so I've also been working with high school students that have reached out to me, and I'll meet with them and go over what NAMI Maine would offer, or what the Youth Mental Health First Aid would offer, or work with them if they want to bring the You Matter event to their high school. And we will be working with them as we create our suicide prevention videos, because we truly feel that without their voice, I'm not sure our messaging would be effective.
With respect to that, how are you working with teens that do need medications, do have, like, need psych medicines? Do you have someone on your team that's expert? Because you can't stop that. There will be some that will need that regardless of what.
Sure. So our alliance, we work with Midcoast Pediatrics, and we also just recently had the executive director for the Maine chapter for the American Association of Pediatrics has joined our alliance. She just happened to move to Bath. So definitely keeping our teens safe and protected is our number one priority.
I just had one other comment. In terms of finance for the H2h project, this is a prototypical group visit. So the provider gets to bill, if you're looking for capturing charges for each person they see. So they're going to capture a list of names on that day with 7 or 8 initials or whatever. They're going to capture 7 charges for 7 patients for that time they're in there. It's actually more efficient than seeing room to room to room to room. So that's the basis for group visits.
Thank you. Great point.
Well, thank you very much for your presentations today. I think it gave us a lot of food for thought, so.
Thank you.
We only have one for each presentation.
Keep it in the area where you have the education visits.
have Kaylee and oops, sorry. I have Kaylee. Yeah, let's announce. I have Kaylee and Brendan, so I need to put Jim on. And are you the ED, Jim?
I am.
And Ashley, are you Ashley Mills? Okay. All right. And what's your role, Ashley? Ashley, what's your role? Yeah.
Director of Health Center Network and I know.
All right.
I didn't make it up.
That's a handle.
It's so funny because I just poached I poached Caroline Zimmerman. She works for me now. Yes. I know, it's the best hire I ever made in my whole life. Yep, hands down. I don't have to work nearly as hard as I used to.
Do you need 6 chairs instead of 4 now to stop them?
No, 4 is great.
Okay.
We're all good. I
Okay.
just only had 2 names in my email from the individual who was coordinating behind the scenes. So yeah, so we're good. No, 4 is great. Director of Health Center Advancement. Is that, yeah, okay. Okay, we gotcha. Beautiful.
The clicker works like all clickers do, and the
Well,
pointer
it's
works.
funny because, so we have it up, and then I can't remember if I don't think,
Oh, yeah.
is it working?
There it
Yep,
is.
there it is.
Okay.
It's a big red button.
Got it.
Just don't touch these two for bigger. Just kidding. I really don't.
Start to
They
hear
just
a timer counting
seriously,
down.
they were like, here. It's okay. Thanks. And obviously, I didn't know who was presenting. So I was supposed to be doing this morning. And I just left the board. So this is like my last official day as a board member. So I had MPHA. And so it was really funny because I had signed up to moderate. It was a morning session. And then one of my colleagues who's on the board was like, she works at Jamie Comstock. She works in the mental health. Yeah. And so she was really like, some sort of coach. So she was like, yeah. And so she like emailed me, I don't know, a week ago, maybe not even. And was like, we don't need to tell anyone. They're not going to know. So I'm just going to send you the presentation. So I got the presentation of yeah. So that was exciting. It's like, okay, I had already like opened my little bios for everybody. Are you Brendan? Are you Brendan? Are you Brandon? Brendan and Brandon are like the worst. I'm like, I get it wrong every time, but it's Brandon. And is it chauffeur? Shaw.
We do need 2 Brandons.
Why?
Because our next panel is 6 people. I'm here. You don't need a chief.
Oh. I'm like, because the guy
He
asked
said
me,
that, no, I know, he said that, and I was like, no, but she doesn't have a panel.
I don't have a panel. I'm like, I'm sorry.
No, it's just one less thing.
Yeah, exactly. All right, I think I'm gonna start to reconvene. Hi, everybody. I think we're going to go ahead and get started here in about 30 seconds, so we'll wait till the last couple of people find their seats. I won't call out any of my friends. Sean Yardley, sit down. Just kidding. All right. Okay, everyone. So hopefully you are in the right place. We're doing our third session, I think, of rural health issues and community responses. And we have 2 presentations in here today. The first is going to be a county-wide model for health improvement. from the Oxford County Wellness Collaborative, and your presenters for that session are Brendan Schaffler, and Jim Douglas. Jim is the ED of the coalition, and Brendan is the network facilitator. The Oxford County Wellness Collaborative, based on what I could gather from Brendan's email, leads, strengthens, and supports the local community in Oxford Hills, and it's a project of Stevens Memorial Hospital. Obviously a lot of partnerships and promotion of health policy as well there. So, and then the second presentation here, just so that we can move things along, and we'll just have them come right up, is leveraging social determinants of health data to improve population health outcomes. And that's going to be Kaylee Hess and Ashley Mills, both of the Maine Primary Care Association. And they work with Maine's community health centers through education, training, and expertise in healthcare policy, quality, and innovation. And so I think we will go ahead and get started right away, and we'll try to keep everyone on time. We'll do about 25 minutes ish for the presentation, and then try to have about 10 minutes at the end for questions. So please welcome our friends from the Oxford County Wellness Collaborative first.
Hi. I'm Jim Douglas, and I will be getting us started. Thank you for joining us for this conversation. We're going to be taking a look at an approach, a way of taking a long-term approach to hopefully significantly augmenting health in a community, a rural community, and I put that in air quotes because our community is the whole of Oxford County. So that's what we're going to be describing, is what we've been building out there, and Brendan will be talking about some of the processes that we've used, and then hopefully we'll have some good questions at the very end. So, Oxford County, you can see the little inset of Maine. We are sort of the far western edge, bordering on New Hampshire. It is a very spread out county. Everything's at least an hour from everything else. Some basic statistics. The numbers up here almost all represent worse than Maine averages and worse than national averages. And I just would point out this median household income that actually is down almost 14.5% since 2000, what is that, 8, 6? So certainly has challenges. This is a slide that shows the results of the county health rankings. This is the project of the Robert Wood Johnson Foundation and the University of Wisconsin. First came out with results in 2010. This is the nationwide data set that compares county to county across the entire nation around about 40 different health factors and health outcomes, and provides a ranking based on those. And you can see that in 2010 and 2011, Oxford County had the lovely distinction of being dead last in the entire state of Maine. We were the least overall healthy county in Maine. That trend, fortunately, has definitely gone up. We were very excited with that spike back in 2015, but as with all lagging data sets, you got to take them with a grain of salt. But what this did was it really provided a rallying call. And the part of the process that was going on at the time were some community forums, not only on the county health ranking data, but also on some early data sets that the Maine healthcare system was generating, and also the early community health needs assessment processes, which require a community discussion of the data that's generated. And basically, in combination with these outcomes, there were a group of people from across Oxford County who were shocked and galvanized to wanting to take some kind of action, and who also were united in strong conviction that these kind of poor health outcome data did not and do not reflect all of what's going on in Oxford County. There's a lot more that is positive there, There was a lot more to be hopeful about there, and decided to take action together to try to do something about that. And that was the birth of the Oxford County Wellness Collaborative. This series of slides is to give you an idea of sort of structurally where does the collaborative fit. So we have Maine Health, of course. Western Maine Health is the local member of Maine Health up in our area of Oxford Hills. Stevens Memorial Hospital is the critical access hospital right in Norway. And Stevens Memorial in Western Maine are the fiscal agent for Healthy Oxford Hills. That's the agency that I'm the director of. It's a healthy community coalition that used to be a Healthy Maine Partnership and is still doing healthy community work. And we are the backbone agency or series of agencies for the Oxford County Wellness Collaborative. The collaborative is not a freestanding 501c3. There was a very deliberate decision made to function as a network and to leverage the capacities of the other organizations that are partners. And there are many other organizations that are partners of the Wellness Collaborative that are also lending capacity to its efforts. So it's not just these, but this gives you an idea of where this falls. Here are some of the results of the actual community health needs assessments that were done. The first one was completed in 2013, and these are county results. These are data sets that were pulled together by all of the major healthcare systems in the state of Maine, plus the Maine CDC, and I believe the University of Maine was involved in analyzing this data as well. And these were the health problems, the health issues that rose to the top of the list according to both the data and then the community discussions about what do we think the priorities are, sort of regardless of what the data suggest. And you can see this is a pretty common list here in Maine. In 2015, shorter list, same characters appearing: obesity, substance use, tobacco, mental health, and health literacy. And then the priorities that were not selected in the community forum process or by the hospitals, which were charged with creating implementation plans based on this data. You can see up here there's some interesting social determinants of health, like poverty and isolation and disconnection, that are highlighted in this list here. So this is just to give you an idea of what the data has been suggesting for Oxford County as issues for some time. And these kinds of data sets were what the Wellness Collaborative formed in response to. So this vision and mission statement and key strategy for the collaborative is relatively new. The collaborative has been evolving consistently and rapidly, I would say. And that's one of the commitments that the collaborative made early on, was to learn from what we were doing and to try to apply that learning on a regular basis. We have been working on finding language that actually captured what we're trying to do to add value to health overall in the county and how we're trying to go about it. And this language is really trying to capture some of that. And what you see in the mission statement in particular is a real emphasis on bringing community members together, building relationships, building strong social capital, and using that as the platform from which to take action. So a lot of work, if you folks have read any of the original writings on collective impact, for example, all of those articles reference the importance of relationships and social capital, and then proceeded to say almost nothing about it or how to go about doing it. And so one of the things that the collaborative we think is somewhat unique in is prioritizing that component, the building of relationships across diverse aspects and sectors of the county community. Okay. This simple little thing is an example of the strategy map platform that we use to help try to simplify the complexity of what we're addressing. We're not focused on a single domain of health. We are focused on basically every domain that could relate to health. And the goal of the collaborative is not to go out and try to identify gaps in work being done. The early founders of the collaborative and those of us coming in since have recognized that a lot of good work was being done, but it wasn't very well integrated. It wasn't very well coordinated. And so the collaborative is more interested in trying to create alignment between different areas of work, different domains, you could think of them as, with the goal of creating health that means, finding the sweet spot of all three of these top layer outcomes: healthy people, healthy environment, and healthy economy. Each one of the work groups has a similar strategy map. It's really that group's vision of the pathway to success. It does not mean that everything is being worked on at once. It just means everyone has thought that these were the important components. What you can see very quickly here, these little pluses, these indicate deeper layers of strategy that has been articulated for that particular work area, that particular domain. So the current work groups that you'll see in a different structure are healthy food, active living, behavioral health, which includes substance use disorders and mental health, community safety, which is largely focused on interpersonal violence prevention, adverse childhood experiences and resilience, and down here the community engagement work group, which is the group really charged with maintaining that focus, that deliberate focus on relationship and social capital building. These other areas we have recognized as really essential to be successful as a community, but don't have the capacity. There hasn't been an upswelling of interest of a group that we could support to take on some of these. We've started to dabble a little bit in the economic development by, dabbling is a little dismissive. We actually jumped in to support some efforts to look at broadband development in Oxford County as a way of spurring economic development, as a way of improving telemedicine, better access to certainly telecommuting and so on. So that's our strategy map. That gives you sort of a sense of how these read from sort of bottom up. And that's all I'm going to say about that. This indicates that same message, that health as we have come to understand it and define it is really at that intersection of personal health, environmental health, and economic health. The core value added that I would argue is one of the major contributions of the Wellness Collaborative has been a commitment to something that we refer to as the mindset shift. We've recognized that there's been a lot of good work going on, a lot of evidence-based, best practice work going on in Oxford County for years, and yet it hasn't seemed to have the traction and impact that we've been looking for. So this mindset shift is a paradigm that we borrowed from the work of Peter Block, who himself borrowed the work of a number of thought leaders in behavioral, small group, and large group change. And basically, if you look at this left-hand column, this stuck community mindset, we also call it the default. This is what happens when you sit down with your friends at a bar or at a party and people start talking. And what they frequently, quickly go to is what's wrong, what are the problems, who's to blame. The only way we're ever going to fix this is if we can call in the right experts and get the right evidence-based practices from somewhere else that we can adopt. There's a tendency to think in terms of somebody should take charge of this and fix it, but it's not me. And there's an underlying tendency to always think in terms of there's not enough time, money, hands on deck, whatever it might be, to tackle this problem. It's too big for where we're at now. In contrast, this mindset shift that we have developed some practices to actually give people an experience of and some skills in reproducing is this restorative community mindset. And it starts with focusing not first on problems, but first on possibilities. What is it that really excites and inspires you as a possibility for economic health, for personal health, for whatever? And moves from that place of Yes, this is a vision. I'm going to keep knocking that no matter what I do. That uses that as the spring point for moving action forward that can unite people and keep them energized. Instead of calling in experts, we focus on inviting everybody who's affected, everyone who's concerned. Similar to that, there's a real emphasis on we have everything we need. We have the people, the resources, the time that we need to get this project going. We can get started right now. There's a real emphasis in what we try to practice of honoring that everyone has gifts to contribute to this process, this effort to create health. Instead of looking to others to fix things, there's a real emphasis on ownership and self-chosen commitment. Here's what I can offer now. It may be something like you can use my conference room for no charge. That's an important assist. It may be I can show up and do childcare at a meeting, so some families who need that support can also show up and participate. We also look at ownership in the sense of not only are we in this together, but we have contributed to the very situations we are complaining about today. And taking an honest, hard look at how do I contribute to economic challenge in our area or to obesity in our area or whatever the issue is part of that mindset shift that we think moves people into a different basis of understanding their neighbors, working together differently, and working together more effectively. This sort of gives you a structural idea of the network nature of the collaborative. Down here we have the 5 work groups. We also have a steering committee that is self-chosen and completely open. Anyone who's a member of the collaborative can come to a steering committee. And we do ask that the conveners of the different work groups participate in the steering committee. Its purpose is not to direct the activities of all the work groups as much as to provide high-level oversight and an opportunity to align the work and make sure that there are opportunities for connecting work that may not be obvious when folks are really focused on the nitty-gritty. Also very focused on funding opportunities that can support the work and move it forward. We finally, have an evaluation team. We, for years, wanted to do more formal evaluation of our work, of the processes we were putting in place, of our hypothesis that it's social capital development that leads to real success in terms of reducing health disparities and health problems. And also to do some hard data production around the outcomes. Are we, in fact, making a dent in those early health outcomes that led us to be the least healthy county in the state of Maine? Finally, we also have a funders group that has started to come together. We've got some incredibly, what's the right word? Far-sighted, experienced, willing to take a risk group of funders that include the Betterment Fund, the Bingham Program, Sewell Foundation has joined, the Maine Health Access Foundation has been an early partner in this work, Quimby Family Foundation has just recently joined us, and Western Maine Health and Maine Health have been our financial stakeholders. But what's interesting about this group is that they have decided to meet on a regular basis to try to have a different kind of conversation and to explore, is there a way of being more equal stakeholders in this project instead of the traditional funder-implementer kind of a relationship that many of us are very familiar with. There are a lot of issues buried in how work like this has been funded over the years, that this is a group that's interested in digging into to get lessons learned and to be able to share that learning across other projects throughout the state of Maine. And with that, I will turn over the clicker.
Thank you, Jim. So, by my count, we have about 5 minutes left. I'm going to try to work through this very quickly, and if I leave anything out, any details that you want to talk more about, please just make a note to ask me questions or ask Jim questions in the question period. So I want to talk really quickly about our community engagement work. So we received funding from the Maine Health Access Foundation, and they said, you should go out and conduct very authentic community engagement. So talk with community members, pay special attention to folks who are normally left out of community conversations and community decision making, and tell us what's getting in the way of health in Oxford County. So we had this conversation where we kind of named all the challenges for health, and then we peeled back layers of the onion to get at the root cause. What was really lying at the foundation of ill health? And these are all different issues, different root causes that surfaced in that conversation. And what really emerged from that was a consensus that isolation, disconnection, and not feeling value was a place where we needed to dig in and start to make a change. This was leading to all sorts of poor health. And MPHA said, that's awesome. Now tell us which health issues specifically you're going to work on. So again, another community conversation, and that led to obesity and substance use disorders surfacing as places to start to make a change. All sorts of very important things came to light in that conversation, and it wasn't us saying, forget about those things, we'll get back to them some other time. It's like, this is where we're going to start to make a difference. We're going to keep our eye on those balls as well, but here's where we're going to dig in, and we agree that we can dig in together on this. So obesity and substance use disorder themselves bundle together a bunch of different things. So obesity is folding in physical activity and nutrition concerns, substance use disorders spanning a wide gamut of substances, so tobacco cessation, alcohol, opioids, prescription drugs, marijuana. And then isolation, disconnection, and not feeling value. There's a lot bundled into that as well. So it's the geographic isolation. It's the fact that Oxford County is hard to serve because of its rural nature. And it's also the physical and social isolation. People may be neighbors, but they don't really know one another. They may have great resources out there to support them to overcome a variety of different challenges, but they don't know about the resources. They don't know how to access them. So a lot bundled in there. So our task then was to take a look at what's in the middle of that root cause and those priority health issues. So we wanted to, MPHA offered funding to make a plan around how we're going to make a difference on this stuff. And this was really this is at the foundation of our planning work, to dive into that question mark, what's in that middle arrow. So we were asking questions about what's the connection between the root cause and our health issues, and how does that connection inform and inspire possibilities for our work groups. So a bunch of different conversations, again, at the community level, to surface possibilities. And out of that came some very common themes. So those conversations, they all included some aspect of connecting people with resources, knowledge, each other, building a sense of the value that we have as individuals and as a community, and encouraging personal commitment, doing a good job at reducing stigma and getting people involved in their communities. So then it was a process of, we have all these things, there's these different initiatives that we have on the table that kind of match those criteria that I had just mentioned in those previous two slides. So then we wanted to ask this additional set of questions. So from all the good things that are going on in the county, what can we build on that really invites action by all sorts of people from all sorts of different backgrounds? Is it something that can be applied county-wide, regardless of whether it exists in one pocket of Oxford County right now? Can we scale it so that people elsewhere can reap that benefit? What's the potential to address the root causes? What's the focus on those priority health issues? And how does it build on what's already going on? How are we not reinventing the wheel, but adding value to something that already has a lot of momentum? And then which things that are going on apply those common themes that I just mentioned as strategies. So out of those, it's hard to see, pardon the color choice, but a variety of different community initiatives emerged there in the middle. So they were kind of a couple focused on substance use disorder, a couple focused on obesity with the possibility that they could address both health issues. So we have the Allen Day Community Garden. The second arrow is the Western Maine Addiction Recovery Initiative, and that's an initiative that rose to deal with the heroin and opioid epidemic in Oxford County, building on the work of 5210 Let's Go, which has really good countywide representation. And then our community safety work groups work specifically around adverse childhood experiences and resilience, and in particular, how to build a trauma-informed school district. So these were all things that the collaborative members decided were great places to start to add value. So we weren't building a program from scratch. It was what's already going on that has all these great attributes that we can add some resources to that's going to make a difference on things we said together that we care about. So a number of different things we learned throughout that community engagement process. We developed a highly intentional, highly refined process that really worked very well for us. People who went through that process often felt like they were heard for the first time. They felt like they were coming to a table and their ideas, their opinions mattered for the first time. They were valued. A lot of folks felt empowered to make differences in the health of themselves, their families, their communities. And it really, in some respects, I don't want to toot our horn too loudly, but I think it was a life-changing experience for some people. We developed a set of very intentional, meaningful conversations that built connections between people, that were leveling, that kind of set an equal bar for the power structures that might walk into the room otherwise. And it's been a great process for us, and I think the community got a lot out of it. I think Jim's going to speak really quickly to that second bullet around our restorative community trainings.
This was the process that we used to try to train and empower some local community leaders to facilitate their own healthy community gatherings. As Brendan said, this was basically trying to pass along the building blocks that we had assembled to have those powerful conversations that matter. It turned out to be a pretty potent experience in this mindset shift that we had been talking about. Something that's hard to put words to, but when people went through these 4-hour sessions, they emerged with a real felt sense of, oh, that's what is different here. And we learned just quickly that, as a lesson learned, that it had a lot more application than we imagined. We had a couple of partners come to us and want this training for their leadership team as an organizational development tool. We've been talking with Community Concepts, a major CAP agency in our area, about using this tool as part of employee orientation to help sort of just get this mindset shift out into the population at large and start to build up that critical mass of people that have this shared way of seeing each other, the value of each other, and what they can do together.
And the last thing is that we're not programmed for collaborative work. We all say that it's great, and we all say we want to do it together. It's much harder to put into practice. It takes continual attention on what that process looks like. It takes continual attention to being transparent, to being honest, being respectful. So we really place a premium on how we manage our relationships with partners, because we know that collaborative work is the answer, but we know that despite best intentions, we need to keep revisiting how we're going to make that work so that we can actually drive towards the changes that we all say we care about. And lastly, this is contact information. You can visit our website. It recaps a lot of what we just spoke about, or you can get in touch with me via that email and ask any questions that surface for you after we part ways today. That's it. Thank you.
Just go for it. I already introduced you, all right, so. But please feel free to say anything else about yourself.
Sure. Oh, someone's doing stuff. This is
Someone
great.
might be doing it for us.
Yeah, they are.
Yes, it's very fancy. All right, there we go. Yep,
Great.
that worked.
Thank you. So I'm Kaylee Hess. and
Ashley Mills.
From the Maine Primary Care Association. I'm not sure who thought it was a good idea to give us a microphone, but we're here, so this is great. These are our objectives for this 25-minute session. And I should get my notes open here for me. This is less of a report out on findings that have already been realized as a result of a project and more about the process of an iterative process within the federally qualified health centers across the state to address social determinants of health, with the goal that we can really catalyze on these efforts in all the communities that federally qualified health centers serve across the state. So these are our objectives for the presentation. You can read.
I'm just going to introduce the Maine Primary Care Association a little bit for those of you who aren't familiar. Our organization is essentially a membership organization of all of the federally qualified health centers all over the state. You can see on this slide our locations are literally Fort Kent down to Springvale in York and Lubeck over to Rangeley. So we pretty much have sites in all of the state. There's about over 70 sites statewide and about 200,000 patients served statewide as well. And, you know, I think when it comes to social determinants of health, the really great part about this project in particular is that the health centers have just kind of a natural inclination. They've been working, providing enabling services to their patients for as long as they've been in existence, which was during the civil rights movement in the 60s. So that's who we are, and Kaylee will take it away.
Great. So there are already today, at this moment, a ton of opportunities that health centers are working on across the state to address social determinants of health. And I wanted to give some examples of those just so that everyone knows some of the great work that's happening. So around food insecurity, Eastport Health Center is partnering with their local food pantry to ensure their patients who really need healthy food, everyone needs healthy food, but maybe diabetics do especially more so, making sure that those patients have access to that healthy food in the food pantries. And there are a number of health centers, for example Health Reach, that is working with the Good Shepherd Food Bank to give out bags of food to patients who identify as being food insecure at their regular doctor's appointments visits. And that's happening all over the place. Transportation, there are a number of cool efforts, and it's a huge need that's been identified. Health Access Network in Lincoln has been really active on this front, including helping to fund a local group to purchase a handicap bus to do some local transportation in their area. That's up in Lincoln. And they've also been in contact with their local taxi service and links on ways to connect with those partners to use transportation vouchers to really ensure that patients can get to and from their doctor's appointments. On the housing front, there are a number of federally qualified health centers that are grantees on a Healthcare for the Homeless grant, and actually PCHC, Penobscot Community Healthcare up in Bangor has, and all over, they're everywhere, they have their own homeless shelter that they run in Bangor. My brother actually works there. So they're doing a lot of really great stuff across the state. Additionally, on the health insurance front, despite all the madness that's going on with the marketplace right now, there in every health center across the state, there are what are called certified application counselors, and they help enroll people in the marketplace right now. So that's one area that's very well covered currently. And in addition to all that, health centers have to provide culturally appropriate care because of the federal funding that they receive from HRSA. And there are a number of health centers that use community health workers to further reach populations that kind of need a little bit of extra help navigating our very complex healthcare system. A lot of you have probably heard of Maine Mobile Health Center. Maine Mobile Health Program, sorry. They used to be Maine Migrant Health Program, and they changed their name to reflect the fact that they really do work more, not just with migrant workers, but also seasonal workers and other types of workers. And then lastly, on the issue of social support, a really great example of work that's being done in a federally qualified health center is with Eastport Health Center. They have what they call a community circle model of engagement, and they've started convening people who have similar needs for example, they have one community circle that works with their LGBT population. And then they also have one for people who are caregivers or acting in a caregiver capacity. So there are just, as a network of FQHCs across the country, there are so many all sorts of wonderful things happening. And in order to kind of move this forward in a more unified front, we, as the Maine Primary Care Association, in partnership with all these health centers, are really starting to focus on food, housing, and transportation, food security, housing and transportation, just to start capturing more of that information about how many of these patients are food insecure, how many of them have transportation barriers, and what can we do about it.
So part of the way that we are focusing our attention in this area is we're using what you have here, seeing on the screen, as well as
probably have it.
what the lovely Kaylee is holding up. This is the Prepare tool. That Prepare is an acronym for the Protocol for Responding to and Assessing Patient Risk, or Assessing Patient Assets, Risks, and Experiences. And NAC, which is the National Association of Community Health Centers, is the organization that put it together, and together with several other organizations listed on there, APCHO out in California, Oregon Primary Care Association, and some other health centers nationwide have been piloting using Prepare at federally qualified health centers. And the idea, initially it's a paper tool, and identifying, this type of information for patients, different social determinants such as housing, money and resources, level of education, military status, on and on. There's several areas here that not everyone is capturing data on, nor are they even asking the patient if they're experiencing this type of burden or whatever the case may be. So this is the tool that we have been working with our health centers on, trying to get them to implement it, whether it's using the paper tool, using their electronic health records, whatever the case may be. And we actually were successful in, NAC has actually put out a Train the Trainer Academy for the Prepare tool, and we were one of the PCAs who was accepted to be a part of the academy. So that kicked off in August, which was exciting, and there are about 7 or 8 other primary care associations around the country that are part of this effort. So working, in conjunction with all of them, as well as some of our health centers, is really how this is being moved forward across the state.
I always make the, it's kind of a joke, it's not really a joke, but it's kind of a joke, that, if I show up to a health center with a housing need and Bobby Joe happens to be at the front desk and Bobby Joe knows someone at the CAP agency who can help with this, but if Bobby Joe's not there, maybe I don't get help with my housing or my transportation or whatever it is. So that's really what the Prepare Academy and using this Prepare tool is all about, is trying to get some of these processes standardized and working well so that all patients have access to the support that they need when they show up having some of these social determinant of health barriers.
And don't tell Bobby Joe we were talking about her here, she will be happy. But the one thing I do want to also add that I almost forgot is in regards to standardization. You just mentioned standardization, and that's the most important piece. If we're going to collect data and we're going to collect meaningful and useful data, the most important thing to have is standardized data, so making sure that everyone is asking the question the same way and receiving the same type of information that they're capturing so that we can actually do something with it. It's meaningful, it's useful, it's real. So that's part of the Prepare.
So it sounds so easy, right? Like, oh, it's a paper form, let's just do this in the health center. We'll just give it to the patient and they'll be able to read it. And I'm seeing, no, it's not so easy. Hence Mount Doom on the screen right now. So it's not that easy. And I think that as public health people, it's easy for us to fall into that trap of thinking, oh, everyone should just be doing this. Why aren't they just helping those people who have transportation needs? Why aren't they just doing this? Why aren't they doing that? So I wanted to talk, and I certainly came into this project with some of those conceptions too. So I wanted to talk about some of the challenges to addressing social determinants of health in the federally qualified health centers, the first of which is huge, is workflows, which I had never even thought about as a specific thing until probably this project. So adding health centers across the state already have to ask tons of questions of their patients because of the funding that they receive from the federal government. So asking any more questions of a patient during a visit is it's one of the most intimidating things that you can present to someone in a federally qualified health center, So some of the questions, I want to just paint the picture for you. So who asks these questions? At what point in the visit? Do you do it using paper format? If so, who then enters the data into the EHR? And if people can't read, what then? Do we ask the questions in the exam room or in the lobby? And if it's in the lobby, how secure is that really, and will you get real answers? Should it be the doctor or the medical assistant who's asking these questions? And does that person have the resources and the training to act on this if a person actually identifies as having a need? Has this person been ever trained in motivational interviewing to solicit this information thoughtfully and to make it not an intimidating process for the patient? And who's going to follow up? And do we need business association agreements with outside organizations? And if we're doing that, how do we protect patients' rights so that we're not violating HIPAA if we tell the food bank that this person is going to need this type of food, for what reason, And how do we code this data so that we aren't just collecting it maybe in a text field in an EHR, electronic health record, but how do we code it so that we can actually access that data later and, cross-tab it and all that stuff that we like to do as public health data people. And then once you find out that someone does have a social determinant of health need, how do we follow up with this patient? How do we put that in the EHR, and who does that work, and at what point during the day? Something that we've realizing, one of our health centers, Health Access Network, has actually been doing this whole tool for about, I think about a year now, and they were shocked at how many patients that they'd been seeing for years were identifying as having pretty extensive social determinant of health needs. And it took about 6 months of them tracking down these patients and really addressing some of those more immediate concerns before, this was one person just tracking down and trying to follow all these patients and making sure they had everything they needed. And it was 6 months until that person could pretty much sleep at night because it was so much work to just get people kind of taken care of. So it's a lot of work, and it's a huge ask, honestly. So the lack of resources, it came up in one of these sessions that I was at earlier, and it's definitely relevant now too. So housing and transportation regularly come up as areas of extreme need in the state. Quite honestly, there's simply not enough housing or transportation right now. Like Section 8 housing, the lists are enormous. The places where you have to live are scary. It's just not good. So something that has come up in our training and in talking with the health centers that we work with on this is how ethical is it to even ask someone about their housing needs or about their transportation needs if we know there are no resources to follow up with on them? And I'm curious, does anyone think that's like super unethical or not? Okay, let's say you think it's okay. Raise your hands if you think it's okay. Okay, not seeing a lot of hands. I'm saying that, yeah, I'm kind of like, so what through a lot of reading and a lot of soul searching about this, we've kind of come to the conclusion that acknowledging the need that the patient has is worth the effort. Even if you can't follow up on it, we've heard tons of webinars and things like that say that just having a patient feel that their needs are being acknowledged is enough sometimes. People know that there aren't enough resources out there for everyone, and right now it's just unfortunate. But not even asking a diabetic if they have a person who has diabetes about if they have access to healthy food and then telling them to go eat a diet full of fruits and vegetables, do you think that that patient is going to really have much faith in the healthcare system? Or someone who needs to someone maybe with cardiovascular disease who needs to get 30 minutes of walking in every day, and maybe they don't have access to, they can't get to a park, or they can't walk safely in their neighborhood, so they have to go somewhere else to walk safely. If you don't acknowledge that they can't do these things, then they're not as likely to have as much faith in their providers and to have as much faith in the healthcare system. And that's what we've been hearing throughout this, through this Prepare Academy, and it is kind of a weird ethical thing to be faced with. Do we ask the question even though we don't have the resources? Yeah, and we acknowledge that we don't have the resources, and asking this question is maybe one way to help get us to that place where there are resources to help out with people on this front. So it's a bit of a sticky one, I understand that. And then lastly, another challenge is the people power to do this in health centers. So people are very strapped for time and energy, and it's really hard to integrate this work into the work that they're already doing. And that's what we're really trying to do with this project. So as I've mentioned, there are a lot of really good things already happening across the state, which is very exciting. But as of today, or maybe we'll say like 2 months ago, there really wasn't a standardized way to track all the efforts that health centers were making on this front, both internally within the health centers, because Bobby Joe wasn't keeping track of all the people who needed housing that she was referring over to the CAP agency, per se, or and externally for all of us to have access to the information that could be gathered in this way, because the health centers really serve a great, it would be so great to get this information from the patients that go to a lot of the federally qualified health centers, and we're hoping that this project can maybe be a jumping off point for that. So however, without tracking these needs, it limits the ability of the federally qualified health centers to advocate for reimbursement for services, because currently these efforts aren't billable. Luckily, the funding mechanisms for health centers kind of buffer that in some way, because they do have this legacy of providing support through their enabling services programs and their outreach and enrollment programs and things like that. But it's not totally sustainable, especially as we ramp up the asks of health centers to include more and more things and require more and more follow-up and more of people's time. And as we all know, it's important to consider sustainability when we're working on these types of projects. So we can't just keep on adding projects without thinking about how to make things like asking about the social determinants of health sustainable and meaningful for everyone involved. So as we see it and as our national partners see it too, Prepare has the potential to really help. Prepare being this tool has the potential to really help out with this on this front. And internally, we have some data collection and aggregation abilities to really pull this data in from all the health centers so that we can hopefully clean it up and have some really meaningful information coming from this effort. And there are a lot of opportunities that come with this. I think you're all probably very clear about that. So community engagement, we can work with patients in the community to try to fix the identified needs that they are identifying through their health center. Sometimes the health center is really the only thing in a community. You know, it's like the major economic driver for Springvale or wherever. So if they're able to get really great information about the needs of their community, it can provide as a unique way to really engage the community too. We can also use this to partner with community-based organizations on areas of mutual interest. So partnering with, and this is already happening to some extent, again, not really standardized, but partnering with CAP agencies on issues like housing and WIC and SNAP-Ed and all these things, and maybe even partner for grant opportunities, which is an exciting idea. Also, the area agencies on aging, so coordinating with efforts on Meals on Wheels and efforts to increase socialization for older adults and things of that nature. There's also the opportunity to partner kind of on statewide efforts, so like the Maine Transit Association, we just recently started a transportation collaborative to try to increase access to transportation for our most rural and needy people in the state. And yeah, so on that front, there are just so many opportunities to partner. Once we have more data about what the patients are identifying as their real needs, it could really galvanize a lot of efforts to bring either more grants in or really the opportunity to leverage all the organizations that are involved in keeping our communities well to just create more good stuff. And I know Joe's gonna like my next point on here, but the presentation on this, the Prepare tool, any information that comes out of it, I think could be really helpful to inform it's not called this anymore, right? Did I do it right, Joe?
You got it right on your slide. I'm so proud.
Okay. It's now the Shared China, the Maine Shared China Community Health Needs Assessment. So we're hoping this could inform that. But it is really hard to get this started because of the ethical issue that I brought up earlier about like the resources not existing, so do you even ask the question? So there's it's a really great project and it's happening and it's going and it's really starting to get some traction, but it is still like slogging through mud sometimes and uphill in winter, molasses, all that stuff, because it's hard to just get this project started. So it's kind of a chicken and egg situation. We need the data to get the resources to address these things, but people don't want to work to get the data until the resources exist to do something about the data. We're working on it. We're working on it. We see a lot of potential for this effort to help with advocacy. So for example, healthcare payment model transformation, including the fee-for-service is not really working, as I think a lot of us probably know, but maybe working with ACOs and things of that nature to increase the opportunities for payment of of the follow-up and the services that something like the Prepare tool could work on. And we're thinking too that once we start getting more statewide data on this front, we can hopefully help align resources in the state with the identified needs that we're seeing. We know right now that patients at health centers, at the federally qualified health centers, do have pretty great needs. They have a lot more needs than maybe, say, I do, or someone in this room, maybe, I don't know. And we need to be able to show that. You know, they're existing with very few resources right now and being asked every year to do more and more and to ask more and more questions of their patients. And we have no real way to show right now that, yeah, our patients have really, really high needs and we need to be reimbursed more fairly for the services that we do provide. So we're seeing the Prepare tool as being a way to help out on that front. So some potential outcomes from all this work, once we get this implemented at all the health centers across the state, people will hopefully leave appointments with meaningful help on their identified and prioritized needs, because someone might have a need for transportation, but they might identify that it's more important to them that their baby have clean diapers. So, it's not always the needs that we see for people might not be what their priorities are, and that's starting this conversation at the health centers is one way to get that ball rolling and to not assume that we necessarily know what's best, but to start that conversation because it's not happening fully right now. And like I said, people will feel listened to and understand that their priorities are also their doctor's priorities. So yeah, I have diabetes, or I have diabetes, and it is important to me to get healthy food because I don't know where to find healthy food, and my diabetes is out of whack. And if we ignore that part of that need of mine, it's not going to serve me. It's not going to serve the healthcare system. It's not going to serve anyone else who's in my shoes either. So there's that. And then hopefully better health outcomes, and people and communities will benefit because of the opportunity for potential advocacy opportunities that can come from this project. So, yeah.
We'll share our question slide with you guys.
Yeah.
Well, thank you. Great. And then we'll invite our Oxford County Collaborative folks to come up too. And we actually have about 6 or 7 minutes for questions. So I think there's a microphone, but if you can all speak rather loud, I think we'll be okay. Our presenters have microphones, so that's the most important thing we can hear their responses. Does anybody have a question? Yes. I think this is also interesting that I'd like to hear any of you guys speak a little bit more, but I am particularly interested in the trauma-informed school work. I know it's early, but is there anything, can you elaborate a little bit?
So yeah, thanks to some very generous funding from Bingham and Betterment, we were working with a rural school district in the northern part of the county to build a kind of cadre of trained faculty as well as trained community providers who would be able to bring a kind of a toolkit or a bunch of strategies into the schools so that students were better supported, students who were impacted by trauma, in a way that we could kind of look at and assess and work on replicating elsewhere. So we're kind of in the middle of that. Actually, we'll be talking more about that at the Maine Resilience Building Network conference in a few weeks. But it's been a strong focus of ours for a couple of years now, and the earlier Stephanie LeBlanc and I presented about crisis intervention team training, and Stephanie's also she's convening a new project to focus on ACEs and resilience kind of across the county as well. So there's a lot of synergy going on, and I think that in another 6 or 8 months, I think we'll really have things, we'll have a process down that we can kind of report out on in a much tidier way and kind of share lessons learned. So it's kind of a stay tuned sort of answer to your question.
I just want to add a little bit about the health centers. I was also thrilled to hear that too. We have for our health centers two clinical leadership retreats each year, which allow for all of the clinical leaders at the federally qualified health centers to come to one room and kind of focus on a topic or many topics. And the one we just had in May was actually trauma-informed care. So we were able to bring everyone together to whether it's medical directors, dental directors, pharmacy director, all of these, these clinical leaders, even social workers as well, were able to get together and just hear from some content experts as well as talk about some next steps that they can implement in order to just continue the conversation on trauma-informed care. I know it wasn't relative to our presentation, but I'm just really glad to hear that trauma-informed care is it's making its way.
And I can add a bit more detail. A couple of elements of that work involve taking learnings from the Reaching Teens Toolkit, which was a toolkit that Dr. Ken Ginsberg offered a training on about a year ago through the Maine Resilience Building Network. So kind of unpacking lessons learned from that in a very digestible way for faculty. And another element of that work is showing Paper Tigers and Resilience, two different movies to kind of foster a community conversation around not just a school-based response, but a community-based response to toxic stress and adverse childhood experiences.
We have time for one more question. Does anyone else have a question that they'd like to ask? Before we bring in our speakers? Oh, wait, yeah.
Okay, thanks. Well, I just wanted to make a comment. I think that recognition of the one-stop shopping that happens at MPHCs, that doesn't happen. I think that other systems are really trying to do that more, as you saw the hospital home piece and so on. But I have to applaud, and they know I'm a huge fan of MPHCs. I have been for many years because integration of mental health, integration of dental health. I can go on and on, but I think that people have really no understanding that model is the model that really works so well, regardless of where you live. It's the whole person, not just here, come in and have your strep test done, and then go to the dentist over there. And if you're lucky, we can get you into counseling somewhere else. So I just have to applaud you guys and the work you do, and support the work, the holistic way that you approach it.
Yeah, the health centers are wonderful.
Yeah.
We'll give them the credit.
Anybody else? Okay. Well, thank you very much, everyone. And
Thank you all.
there was a handout from Maine Primary Care Association. We didn't have enough copies for everybody, but it will be posted up on the website with all of the materials from today. I let our executive director know, so she has a copy and will be able to put it up there if you're interested in looking at the Prepare tool. Thank you.
Oh, yeah, uh-huh.
Down at a conference in Houston about collaboration.
Oh, right.
Just started at that
She
point.
had just started.
Yeah.
Oh, yeah.
Very soon.
I told Roy to yank one of our hot pickles.
Now she's deep into it with us. That's great.
Let's see. So lovely when we got the chance to talk.
How long have you been?
A little over 2 years. Yeah. So my background is in public health, so I'm still fairly new to philanthropy, relatively speaking. Yeah.
I feel new to it too, although I realize it's almost 10 years.
I don't know.
I left, I was in the,
You are who you are, Carol. Just celebrate that.
learning all kinds of things I never
Weird.
thought about.
Be weird.
Oh my, this is how I feel like I finally approved it. Oh, excuse me, excuse of saying I'm new though. I have to.
I know you can't hide behind it
did
too
too.
long.
I did too.
People don't have much patience.
What was last
This
evening?
time, family invited some folks to either
Hello, Becca.
advisors or friends
I got to see you with the policy panel.
yeah.
This is great. This is very good.
Yeah, it was nice to have for dinner. Yeah. Thank you. Thanks for doing that.
Sure.
And had Becca, you spoke, Becca spoke. You know how Martin spoke? But yes, all right, that would be great. Thank you.
Big rabbit hole inside.
She don't hug. She's thinking. The air is just getting drier.
I know, but it feels pretty darn good. Finally, we got a frosty morning.
And the moon is just a tiny
Yeah,
little
the
sliver
sliver.
right over the horizon.
Yeah.
And the stars are so
We're out way before sunrise. It's so fast how quickly it's going.
Yeah, do it.
Yeah, almost 7 o'clock.
Daylight savings, when do we fall back?
First, I think it's the first Sunday in
Yeah, Marty Groen flipped out of the Democratic Party.
then it'll be very dark.
I wonder what.
Saturday morning when you wake up.
They said it's snow. Okay, so tell us, why did Marty? Was it labor stuff that he was getting sick of? He said it was special interest when he was interviewed.
It's
my job to make the other funders fall down on the job.
No, as long as there's no fillers question.
Well, we're going to close her down here today, so unless people are
Yeah,
really
you
looking
do
for money.
get pressured
You're
to
gonna be outta
as
here.
a block.
Yeah,
Things because you need a block.
That's it.
360 people.
Is that how many people signed up for this?
They were expecting to award is the most by party that represents good problem years ago, and that's really.
It is. I went to 2 workshops after lunch. I went to the panel before lunch too.
So, and I see
They were good.
today.
To the quick story ones,
Really?
which I like because it's about as long as I can.
Well, there was a Republican about 2 weeks
They
ago.
were very
It's
good.
a different one now. Do you remember?
A lot of good stuff going on in
So, hello everyone. I want to welcome you to our last panel today. Just a few highlights. We had 360 people here today, which is a new record for MPHA. Really thrilled with the turnout, and it's just really, really exciting to see so many people working in public health and coming here today to be part of our day. So I know we fit a lot in, but we also had a record number of abstract submissions and a lot of really great presentations. So thank you so much for being here. The slides from all the presentations will be available online, so if you weren't able to get to a session that you were interested in, you can still see the presentation later this week. So with that, I'm going to turn it over to Megan Hannon from the Maine Women's Fund to moderate our funders panel. So thank you very much.
Thank you. Ooh. That can actually work. Hello. Yes. Thank you all for sticking it out. I know it's always fun to be the last person on the agenda. Today we're going to have a kind of informal conversation with some of the larger and smaller, but some of the major funders for health and public health in the state of Maine. So I'm just going to do a quick introduction and then have everybody again say their name, their organization, a little bit about it, what their priorities are, how much they have in endowments if they have endowments, and about how much they grant each year. Does that sound good? So I'll go from the other end, not that I can even see you over there. We have Carolyn Woolen from the Betterment Fund, and to her right, Lisa Miller from the Bingham Fund, Barbara Leonard from Maine Health Access Foundation / MPHA, JSB from the Elmina Sewell Foundation, and Aisha, I can never spell your last name. Sheik, easy. Aisha Sheik from the Maine Cancer Foundation. So do you want to start, Carol?
Sure. Hi. As I was introduced, I'm Carolyn Woolen. I'm a trustee of the Betterment Fund. The Betterment Fund is a private foundation which operates solely here in the state of Maine. It was founded by William Bingham, who lived in Bethel, Maine, and therefore we have defined our primary geographical interest as Western Maine and by extension the rural areas. So we don't really do very much in Portland or along the coast. We have a broad base of interests: conservation, education, health. Health is just a part of it. We have almost $40 million in assets, and we make grants of about $1.8 million a year, but probably only about $200–250 of that is actually in health. Our focus areas in health are, and we try to define this pretty well in our website so people know whether to apply or not. First of all, we're very interested in health careers of all sorts, helping people all the way from technicians to doctors qualify here in the state of Maine, both because it's important for the provision of health care, and also we think that those are good careers, particularly in the rural areas. Sometimes they are the best careers. We are also a big funder of oral health, as are a number of other people on this panel, and you might ask, what's the deal about oral health? People, the funders seem to be talking about it, and we could all go on for a long time about that, but basically oral health is a great prevention-based area, and darn it, it's a problem that ought to be able to be solved here in Maine, and it would really contribute to the health and the employability and the education of our people if we could get good oral health for all of our people. We are also interested in public health, generally public policy issues. And finally, we do some grants which I would describe as community-based health initiatives, especially for those who have the fewest resources. We also have a kind of a subcategory that we call moving communities to health, and that's kind of where we put conservation together with health and look at communities who are using their natural resources to help individuals get out and get moving and have a better lifestyle for themselves. So those are our areas. You've asked, we do give project support, but we also, especially after we get to know an organization and have a good sense of what we do, we will do operating support, and we're a little unusual in that we do make often 3 years of grants. I would describe ourselves as place-based, and I think that's the basics.
So I'm going to tell you about a sister organization of Betterment. Mr. Bingham was very generous, and he plunked large amounts of money in several places, and he plunked a lump in Boston. And that is what the Bingham program is. Our mothership is a hospital in Boston, Tufts Medical Center. I'm Lisa Miller. I'm Senior Program Officer. You probably know Karen Heck as well. She's my co-Senior Program Officer. We are a rather small foundation. We consider ourselves such. The endowment's about $13 million. We give out, in a good year, $800,000, and sometimes it's around $550,000, $600,000. Excuse me. Our sort of classic areas of giving, a historic area for us is health professions development and improvement. That's really low these 80-plus years ago that all the money went into. But as the years went by, we also added community health, and we did sort of start funding the healthy community movement in Maine. And then as a couple of other staff people like myself and my former boss came on board, we began funding in public health policy. And I would say that's where a huge lump of our funding is now. What else did you ask? Did I do it? Oh, we're statewide. We also give out what we call discretionary grants, which are kind of small, and they're rolling. And we give out grants a couple times a year. And we do have an interest, a very big interest in rural areas. So I can talk some more about some newer priorities we have when we get to our other questions.
Let's see. That is working. Okay. Hi, Barbara Leonard. I'm President and CEO of the Maine Health Access Foundation, and we are the largest foundation that is solely focused on health and health care in the state. We are certainly by no means the largest foundation in the state that does things related to health. We focus on promoting access, on better care, and on improved health. We have an endowment that's at about $122 million right now. We are a foundation that does not only grant making, but wraps things around that grant making, like convening grantees and technical assistance and evaluation. And we have a relatively larger staff. Our staff is 10 people, and of that staff, all but 3 of us are solely dedicated to the grant-making side of the work, either on the grants management side or in the program officer realm. And those folks really get involved and engaged with the grantees whose programs they manage. So we try not only to provide dollars, but we try as much as we can to learn from and also provide support to those dollars doing their work. We make grants and program expenditures in the realm of $4 to $5 million a year. Those program expenditures cover some of those things like the technical assistance and the evaluation, so it's a little muddier than simply counting our grant making. And I will stop right now so that we can get through the panel, and then hope I can touch on some other things as we get into the questions and answers.
And See if I can, oh yes, that's good. At least I thought we might do a rap later on if I could get the bump, get that. Jay Espy, Executive Director of the Elmina B. Sewell Foundation. Mrs. Sewell was a Kennebunk resident and founded this foundation in 1982. It was when she died that it actually became quite large, and that was 2005. And it went from $18 million to $180 million. And we make about between $8 and $9 million in grants each year. We're focused in Maine, though we do have some what we call legacy grants beyond the state's borders, honoring some of the relationships that Mrs. Sewell had with some organizations out of the state, but that's a very small number. We get requests all the time for, how do I become a legacy organization? It's too late for that. But we continue to focus on some of the things that she cared deeply about. Animal welfare was one of the things that she cared deeply about all of her life, was the founder of the Animal Welfare Society in Kennebunk, and really tried to help professionalize the animal welfare sector in the state of Maine. And we have a program that is dedicated to that, focused on the unwanted cat population and how we reduce the number of unwanted cats in the state of Maine. And secondly, on sort of the capacity of the sector, particularly the shelters, that network of shelters around the state. Our largest program is something we call Healthy People, Healthy Places. And 3 years ago, we took what we had then was our program on the environment, and then a program called Human Well-Being, and decided that we shouldn't be having two silos, environment and human well-being. We should bring those together, and that was what resulted in Healthy People, Healthy Places. And there are sort of two sub-programs under that. One is this integration of environment and human well-being, but also a recognition that there are many people whose basic human needs are not being met in the state of Maine. And so we have a program that's focused on system change to assist in helping folks meet their basic human needs. That program we've been running now for 3 years. It is on pause for the next year as we really try to hone in better on what we mean by basic human needs, what we mean by systems change, and how we can have greater impact in that arena. So we will continue to make grants in that area this next year, but only for two organizations that have been receiving grants in the past. And that's because we don't care about anybody else, but we really need to figure this program out better. And I've mentioned legacy, which is kind of a closed deal. Did I say we give $8 to $9 million in grants a year? So, okay, I'll turn it over to Aisha.
Hi, my name is Aisha Sheikh. I'm the Director of Programming at Maine Cancer Foundation. I'll maybe start with what sets Maine Cancer Foundation a little bit apart from the rest of the funders sitting here, which is that we're a public foundation, which means that we raise all of the money that we grant back into Maine communities every year. So you may have heard of some of our bigger fundraisers like the Try for a Cure or Twilight 5K. Maine Cancer Foundation is about 40 years old. Our mission is to reduce cancer incidence and mortality in the state of Maine, and 100% of the money that we raise is reinvested or invested back into Maine communities. So we like to describe ourselves as 100% Maine, and all of our work is focused on helping Mainers in their fight against cancer. Until about 2015, approximately 80% of the funding from the foundation was dedicated to cancer research in the state. And while we knew we were doing good work, the board paused in 2015 and decided to change the focus of funding towards other priorities. And many of those are focused on public health. So we launched in 2015 a very ambitious goal that we call Challenge Cancer 2020, which is to reduce cancer mortality 20% by 2020. And so that initiative really guides all of our grant making. And so the three pillars of that initiative are to focus on cancer prevention, early detection, which includes screening, and improving clinical outcomes, or patient outcomes, which is kind of a bucket for things like transportation or access to clinical trials. So while you're hearing me say the word cancer over and over again, I work with so many of you on cancer-related issues, thinking about obesity, exercise, access to care. So as you're listening to me talk more about the foundation and partnering, please bear in mind cancer overlaps with so much of the work that I already know you're doing. And I could keep going, but I'll stop.
Great. So that's a good place to start. One of the burning questions that I know people are thinking about is, do you all, I'll leave myself out of this for now, do you all work together on initiatives, or do you talk to each other about initiatives so that there can be, I'll put in 10,000 here, you put in 10,000 there, and we can do things together? Anybody?
You.
So Lisa.
We're all laughing
We
because
work together as to who's going to answer the question.
we might as well share bunk beds. Yeah, I would say actually maybe 15 or 20 years ago, you would not find that foundations in Maine worked together much. We were all very siloed. And now we're doing it a lot. There's an oral health funders group of about 10, I think. Which I founded. There's an early childhood funders group. There was an environmental funders group that may still be operating. Immigrant and refugee, opioid funding, and aging. There's some work around aging now. And in fact, there's a tri-state collaborative of funders around aging for the Tri-State Learning Collaborative on Aging. So there's a tremendous amount of collaborative work going on among funders. We are now walking the walk that we make you walk, which is we often want you to collaborate, and please know that we are too. There are difficulties that are unique to our industry. It is not as easy to streamline our doggone applications and reports as you would like. We're working on it, but it's a hard process for a bunch of rigid old people. You're not so old.
No, nor rigid sometimes. So one of the other challenges with working together to put 10,000 in and 10,000 in and 10,000 in is the place where that money goes. So if we want to try to do it in a way that's easy for people applying, we have to find a place where those 10,000s can go so that it can go out in a more focused lump of money, lumps as Lisa was talking about earlier. Or sometimes we have to do this really complicated thing where we have people apply to multiple ones of us, which we hate to have to make you do. So we are trying to figure out how to do this better. And I encourage all of you who work with the categories where there is some combined funding to just keep giving us feedback about how it's going when we are trying to do collaborative projects with you and among us. And if you can't figure out why things feel complicated or clunky, just ask us and we'll tell you why we're doing it in a way that may feel weird. Just like all of you, we all have boards and or boards of trustees or advisors that may make decisions at certain levels of funding. So there are times when we have to time our funding decisions to meet their timelines, and they may be different across organizations. So we do work together. We're trying to do it more. And in addition to actually putting funding together, I think we're also, as a sector, communicating a whole lot more. So we may have staff or grantees or board members who are on advisory committees or reviewing grants or doing brainstorming with one another's organizations. I think of the Sewell Foundation. One of our board members is actually a staff member on the Sewell Foundation. One of our external grants committee members is a Sewell staff member. So that's the other way we're trying to be a little bit more coordinated.
I wanted to mention one small step that Betterment Fund has taken. Last year, we changed our application, which had a lot of sort of, I would call, qualifying questions like, you know, what's your area, what's your geographical area, how much are you working for? But then we had a whole series of distinct questions that had you describe your project, and realized that that made it a lot harder to take the work that you had perhaps done for someone else and fit them into the order of our questions. So we got rid of a lot of the middle questions with the idea that hopefully that would make it easier for some of you to say, oh, wait a minute, I'm asking for the same thing that we asked Sewell for. Maybe I could just kind of slap that into the body of the application. Similarly, on our report we have that is due a year after your grant, we have very few individual questions, and so that you could append a report that perhaps you had done to a group of funders. And then a lot of the times as we work together more closely on doing our funding, we actually encourage a group report and can kind of get away from some of each one's deadlines and say we'd like a report that goes to all of us. Recently, the oral health funders made a grant to 6 different communities working on children's oral health. We managed to actually have all of the contributions from each foundation made into a fund at Maine Community Foundation. And we're working with all of the grantees collectively, and all of their reporting is collective. So they really don't even get into who gave, among the foundations, who gave what money.
I just wanted to provide an example of it was a wonderful opportunity for Maine Cancer Foundation to co-fund a project. About a year ago, Paul Hahn was speaking with Bristol Myers Squibb Foundation about a lung cancer screening project, which you may have heard about earlier today, the Maine Lung Cancer Consortium, or collaboration, sorry, Leo. And Paul approached us and said, Bristol Myers Squibb is really excited about this project, but they need a local co-funder. And so he asked us to be the lead co-funder for the project in Maine, and it was a wonderful opportunity. We were really able to work with the application they put into Bristol Myers and fund the project at $100,000 over 4 years, so $400,000 total. We're lucky we have the flexibility of, we're a pretty nimble organization. We have a great forward-thinking board. And so if you have ideas that you think may be relevant to the foundation, I don't think you necessarily need to wait for us as a foundation to talk about co-funding. I'd feel free to approach us and say, we got a $20,000 grant, but if we had $20,000 more from you, this is what we could do. Or we could do it for over more time, and that would have just such great impact. So I encourage you to think of it that way as well.
I would just add, one of the things the Environmental Funders Network did a few years ago, these were mostly, there were some health funders involved as well, was a pooled fund that would then be used to try to move quality of place work forward. What we found, we abandoned it after 3 years, and what we found is that we in effect created a new foundation and a whole other set of applications for you, and for ourselves, a whole new set of applications to review. And it didn't, and we were still getting we were still getting proposals from all of you in our individual rounds. So we moved more to an aligned funding kind of a framework where that involves more communication among funders. We're on a longer term, we may not know precisely the project you've sent to Carolyn or any of us up here until we get together. But over time, we're learning more about your organizations often and are sharing our knowledge about that. And that can help as we think about particularly issues or place-based giving. You know, who are the players out there that we need to be in contact with, and how can we coordinate our efforts with your efforts to put money where it's needed most? And I'd say that we're trying to do more of that. I also have a pet project, and I'd be interested in your reaction to this. One of the things that we've talked about, because we had a presentation a couple of years from a group called, I can't remember the name of the group, but they do finance work. Nonprofit Finance Fund, and it was because of MPHA's work with them. One of the things we all ask for are budget information from each of our grantees. Is there a way that we could somehow unify? We may not get to a common grant application. We actually tried that through the Maine Philanthropy Center some years ago, and it really didn't work very well. But to the extent that we could have standardized budget reporting and or just budget information that comes with grant applications, it would make our life easier. We'd know that we were asking you to give us the right information. You'd know what information to give us, hopefully in a way that you could then share without having to create it again for all of our applications. We're not there yet, but it's been discussed, and I'd be interested at some point when maybe we get to audience participation. People like that idea.
Actually, one of the reasons that didn't go forward is that our last meeting about it somehow got planned for the day after the election. And November 5th somehow, or 7th, or whatever day, 9th, just wasn't the best day for us to all be collaborating on anything, if you know what I mean.
Okay. So you guys have actually talked about a couple of things that I've been thinking about, and I think the audience has been thinking about, but something that Carolyn said at the very beginning. I tried to write it down, but I don't think I'm going to quote you correctly. But, you know, this is a problem that needs to be solved. When you are thinking about what you want to grant, what kind of projects you want, or more generally operating support, if you're going to give operating support to this organization because you know this organization does good stuff, how do you decide what the problem is you want to solve in a more precise way than, you know, access to health care? And then how do you choose your grantees based on solving the problem you think is solvable and you think that they are able to help solve? Does that make any sense? I kind of rambled there.
I can start, if that's okay. I mentioned earlier that at Maine Cancer Foundation, we have our current initiative, Challenge Cancer 2020, which really guides our grant making. So that's a nice template that we can use when we think about what our plans are for the following year. But we really look to the data that's available to us. So we look at the Maine Cancer Registry, and just as importantly, we look to our colleagues. We have, I think, about 3.5 people on staff dedicated to grant making and programming. And so we also know what we don't know. And so I can see in the audience, many of you I've tapped for your expert advice in helping us choose where the priorities are. And we also we do our best to stay very mindful of any changes in public policy, and we're all very familiar with the public health funding that has changed considerably over the last couple of years. And we feel a great responsibility to help whenever we can and when appropriate and when it fits with our overall grant-making strategy. Does that answer your question?
I said we had sort of 3 historic funding priorities, but we are like the Maine Cancer Foundation, a sort of small, nimble organization. We are Augusta-based. We sit and because we care about public health, we watch what goes on over in the legislature and in government and the executive branch. And we have a very informed board who says to heck with the historic guidelines. We've got a crisis in Augusta. We've got all the things that we've cared about for years being defunded. You need to be funding advocacy. So we're able to be flexible and sort of shift a bit. And another area where we did that was some years ago. There was a burst of domestic violence murders. You may remember it was just a cluster that knocked all of our socks off, all of us who care about public health. And our board said, we got to do something. You know, what can we do with our little bits of money? And the more we dug into the issue and really wanted to get back to primary prevention, which if you're interested in public health, you care about primary prevention, it got us into the world of adverse childhood experiences. This is 15 years ago. And we have, almost 15 years ago, we have invested in that issue and that topic, that foundation to all public health issues for now 12 to 13 years, and we've been authorized for another 10, which is very unusual for foundations to invest that long in something. So we're able to respond a little more quickly sometimes than I think some other foundations to emerging issues. And I only want to just do some shameless promotion, and you got this in your packet, but we are having a conference November 2nd and 3rd about the intersection between adverse childhood experiences and public health work. And we encourage you all to come. If you don't know much about it, corner me after the program.
We try to maintain a balance between longer-term change that we're trying to achieve and being nimble and addressing things that happen. So when the Affordable Care Act first passed, we were deep in the midst of trying to advance our work on integrating primary care and behavioral health, and maintained our commitment to that because we were getting some traction. And we looked at the Affordable Care Act and said, what do we need to do immediately on that? And the ACA passed in March. By June, we had money going out the door to advocacy organizations so that they would have enough funding to actually be down the hill in Augusta, paying attention to what was happening at the state level as things were rolling out from the federal level. Fast forward to more recently, our board and our community advisory committee help us decide what our longer term strategies are. We listen a lot, or we try to our grantees to pay attention to what's happening in the world. And in the past couple of years, we've rolled out programs looking at rural health systems because we know they're vulnerable and they are fragile, and we have a lot of people living in rural areas in the state, and a lot of them have disabilities or are aging quickly. And if those rural health systems aren't kept alive and vital, there's going to be some real problems there. And we put out a grant opportunity last December around the opiate epidemic, and picked a narrow slice of work relative to that epidemic, which is trying to expand medication-assisted treatment in primary care, but really tried to move quickly there. We also do some work that tries to get information out so that people who are doing advocacy are able to use that information. A couple of years ago, we worked with a national organization called MANAT Health Solutions and put out information about the impact of expanding Medicaid in Maine. 2 days from now, you will see, if you're signed up for our electronic newsletter, 2 new fact sheets on Medicaid in Maine, again, working with MANAT Health Solutions, that provides information about the Medicaid program, who it covers in this state, how it's paid for, what the federal match is, et cetera. And that will be coming out this fall, and we'll probably publicize it and get it out again early in 2018. So we try to balance longer-term initiatives that are trying to achieve specific things with being nimble and responding to policy and environment and political environment issues as quickly as we can.
Barbara used the important word of listen, and that's why we're all here today. We didn't just show up for this panel. We were at some of the earlier sessions too. We try to listen to the people of Maine a great deal. For instance, last night I was at an oral health fund meeting. I'm here at Maine Public Health today, and tomorrow I'll be at the GrowSmart annual meeting. So there's a lot of information coming that we can kind of then take back and try to process. The other thing is that we do have an open application system. even if you call me and I say that's the craziest idea I've ever heard, you still can apply. And maybe the other 5 trustees will think I'm cuckoo and that your idea is a great idea. So, and we always view our application process as a way for us to learn what we think, what you think is important, and then we can discuss that. And I know that Sewell gets a great deal of its information from the millions of applications that you all get, Jay.
Yeah, and I would say we're kind of an example of a not-so-nimble foundation right now, which is part of the reason for the pause in the basic human needs area. For some structural reasons, we've been doing 1 grant round per year in the Healthy People, Healthy Places program, and then again in the legacy and animal welfare programs. When we're talking about needs that spring up, having 1 application round a year for each of those areas is difficult. We too, I think, like you've said, we have an open application process, so anyone can apply pretty much for anything during those rounds. We're trying to focus more and give more feedback to those applying so they can get a little better sense of what we're like, what's closest to the target or the bullseye for us. And in the basic human needs arena, we're really looking at how we make grants very carefully. Should it all be a board decision? Or should we have advisors and more community participation in that? What are the issues that we really should be focusing on? So we're trying to figure out how we can be more nimble in terms of timing, how we can be more responsive to need as it develops, but I can't say that we're there yet.
I'd like to just follow up on one thing Jay said about applications. We sometimes get phone calls and emails asking, does this sound good? We don't really have a great process for handling that, but we do say on our website, if you get the application in within 7 days of the actual application date, we will review it and we will get back to you. And I cannot tell you how few organizations take advantage of that. It always surprises me. And there are a number of times I see applications and I think, oh, I wish I'd had a chance to talk to them before this got put in concrete. And Lisa, I know you all are really good about talking to people on the telephone, and you're very direct about how you handle that.
This is where foundations are different. We require that you call us before you submit. Even if we've maybe talked about it 3 months ago, you need to remind us we talked about it. You need to call in and say, this is coming in. First, we want to be sure it's, really in our wheelhouse. Second, we want to save time for you. Third, we want to save time for us. And fourth, if we got 8 applications for arsenic, that's a lousy competition round for anybody. So, we might advise you if you're not totally ready to come in some other time. So we kind of look at what the round's going to look like, and we try to discourage you if we think it's just not a good fit. We don't want you to waste your time.
Okay, we are running very short on time. Does anybody have a burning question for the panel? Okay, then one last question for all of you. We can go in any order that you want. What is it that makes you love to go to work every day?
The grantees.
Wow.
Absolutely. It's great sitting here looking at some of you in the face. That's why we do it.
You've funded almost every one of them, haven't you?
A lot.
So I confess I asked Megan earlier, what are you going to ask us? And she tipped me off to this question. And then I spent all day thinking about what I love about my job. Obviously, it's not hard to care about cancer. The work has deep, deep meaning for everybody, I think, that we work with, because it's everywhere. It's the effects of the work that we do. It's hard as a funder because we're not doing direct work with patients sometimes to feel the results of our work, but was in Washington County a couple weeks ago, and I was able to meet a patient navigator and one of the patients that she has been helping who's in treatment. And there's just so much potential with the funding, and it's very rewarding to see that. And I just have to give a big shout out to my coworkers and my colleagues who make my life that much easier. I learn so much every day from especially the grantees.
And I would say that with all the bad news in the world and the stories of how everything's going south, and that people are doing bad things, and there are people living off the system, and it's, you know, it's not fair. There are some amazing things going on throughout the state of Maine, and that gives me a lot of hope. And I'm hoping we can actually, as funders, start to help tell your stories of really great stuff that's happening in Maine, and it's happening at the community level, and it's people from all walks of life working together, and those aren't alternative facts; those are actual facts.
True facts.
What gets me up in the morning for my job is that we are so flexible. It's envied by some other foundations. And in this world of funding advocacy, for example, and watching Augusta and watching public health funding just drain away, we spoke with our advisors and we said, you know, there's tons of federal money they're just turning away or not applying for. And they said, yeah, well, how much? And we said, well, we don't know. They said, go find out. So we commissioned a study that the Maine Center for Economic Policy did, and maybe you've seen it. You know, I've heard it cited twice today that about $2 billion over the past 6 to 8 years has been turned away in federal funding. That was a study that we initiated, and it's really gotten a lot of play. So that's fun. That's fun. I love my job.
I always say I've got the best job in the entire world because I work with two groups of people. I work with my co-philanthropists, and we really see a lot of each other and work together. And then I get to work with the grantees. And what that means is that everybody I'm working about cares about something bigger than themselves. They are all putting efforts into helping other people, and that's what makes me jazzed all the time.
Awesome. I'm just going to share mine too, just because. Yeah. At the Maine Women's Fund, right now, at this place in time, with Me Too all over my Facebook page for 2.5 days now, it is like anything can happen every day. And it makes me so excited to be in this work, to have moved from public health advocacy into the philanthropy side of it has been really exciting. And talking to you guys today and being with all my old peeps today, we're called the dinosaurs. Thank you, Barbara. It's been a great day. So is there anything else I need to do, Becca? Are you coming up? Thank you, panelists.
So I just want to thank again our panelists and our moderator, and thank you all for staying here today and for coming to our 33rd annual meeting. And we look forward to seeing you next October. Thanks very much.
Nice meeting you. Yeah. I hope so. Yeah, I mean, you gotta start hanging out with this gang.
I think that's great. So I do finally get up. That's what
Are you well? Is Cancer Foundation? Oh my goodness! Oh, well, thank you. That's nice.
I don't say it like every day. She does.
My wife.
Yeah, just like
Take this away from me.
Yes, so good for you.
Thank
you.
Yeah, thank you.
Nice to meet you. Thanks.
That is
very
thank
nice.
you. Thrilled to have you. Thank you. Thanks very much.
Barbara, right?
Yeah, right. Barbara.
Thank you, Megan.
Yeah.
Edric, yeah.
There are days. I do.
And it was
Pretty narrow.
important.
And I do say that a lot.
There was a curiosity.
Yeah.
The what?
Yes.
Program officers.
Now, remember, I'm heading off on my world tours.
I don't know. Yeah, I'm not sure how frequently that's.
Yeah.
I need to look at that too, but I know we all have our busy.
No, I think.
No, always the way. Yeah. Well, nice to meet you.
Like I earned my glass of wine today.
There you go. Here's a glass of wine. Here's a glass of wine. Not here. No, I was going to say you're going home.
Thank you, yeah, that's a good idea. I should look there. I didn't look there.
Thank you both.
Yeah, thank you. Nice to meet you. Yeah, thanks.
Nice work.
Great idea. I'll look there. I didn't look before. Yeah, I didn't know that existed. Yeah, no, until you just told me everything. That's great. Yeah. Well, thank you again, Megan. It was nice to have you here. Thanks very much. Yeah, thank you so much, Carolyn.